Hey guys, welcome back for another episode of 5 Minute EMS Review, where we give you short and to the point videos on different EMS topics. Today, we are looking at the EMS medication adenosine. Let's get started. Adenosine is classified as a miscellaneous antiarrhythmic and is a naturally occurring substance. It is a nucleoside or a subunit of nucleic acids. Now, what do we use it for? Adenosine is indicated for conversion of SVT or supraventricular tachycardia rhythms. So anything that is fast and is originating above the ventricles, supraventricular, we can use adenosine to help us slow down. It's basically our chemical cardioversion. So just as we slow the heart rate with electrical cardioversion, we can also slow the heart rate with this chemical cardioversion, adenosine. Now, the difference here is that typically electricity is used for us when we have an SVT presenting with serious symptoms and a very unstable patient. We're going to go with electricity in that situation. Whereas with adenosine, it may be more beneficial for us in a situation where the patient is more stable in an SVT, but they are not having serious signs and symptoms, and we simply need to slow their rhythm down. Your local protocol should have some guidance for you to help you determine when you would use one or the other. Now, the caveat with adenosine being useful for SVT is that it is not considered effective for atrial fibrillation or atrial flutter. However, if you have diagnosed an SVT rhythm, but you're having a hard time determining which SVT you're dealing with, and you potentially may have an underlying AFib or A-flutter that you can't quite identify, using adenosine may slow down the rate long enough for you to identify the rhythm and determine that you are dealing with an AFib or an A-flutter. So it can be helpful in that situation, but it should not be expected to convert an AFib or an A-flutter. If you do use adenosine to slow it down and identify an underlying AFib or flutter, make sure that you are cautious about using more than one antiarrhythmic in succession and that you consult your local protocol for doing so. Now, what exactly does adenosine do for us? It slows down AV or atrioventricular node conduction, and it inhibits AV re-entry pathways. Let's remind ourselves that a re-entry pathway is when we have an electrical impulse that is conducted back to cells that have already depolarized and causes them to depolarize again early, leading to an arrhythmia. So in our case, adenosine helps to prevent re-entry pathways through the AV node. So circular impulse conduction back through the AV node, trying to depolarize the cells of the AV node and surrounding area early, again, leading to a tachycardia. So we're trying to inhibit that along with simply AV conduction from the top down through the AV node. Now, specifically, adenosine affects slow action potentials of the SA and AV nodes by decreasing the flow of calcium into the cell and increasing the flow of potassium out of the cell. What this does for us is it causes the cells to be made more negative or hyperpolarized. This causes a decrease in the rate of depolarization and a slowing of our heart rhythm, ideally, so that we can get back to a normal rhythm. Now, there are little effects on the fast potentials of the ventricular conduction system and the cardiac muscle cells. For our dosing, the initial dose is 6 milligrams rapid IV push. If this is unsuccessful, you can repeat with another 12 milligrams. And if that's unsuccessful, you can go a third dose also at 12 milligrams. The key here is that these are rapid IV or IO push followed by a rapid push of normal saline. The point is that the half-life of adenosine is less than 10 seconds, meaning that in less than 10 seconds, half of the medication will no longer be active in the body. So we have to get the medication to the heart quickly. I've seen some people use a 3-way stopcock attached to the IV, pushing the medication and then switching to the other side of the stopcock and following with a rapid saline flush. I find that a little bit awkward to maneuver with. So my preference is to have a bag of normal saline, pushing the adenosine through the medication port with the tubing pinched off, releasing the tubing and following with a rapid squeezing of the bag of normal saline to get that hard push of saline behind the adenosine. Now, the adverse effects that we can deal with: facial flushing, chest pain, headache, shortness of breath, bradycardia. These are all possible. In addition, if you are successful in converting the rhythm, you should suspect a short asystolic pause between conversion and restoring of a normal heart rhythm. So don't get bent out of shape if you see a short asystolic pause immediately before your restoration of a more ideal rhythm. Now, adenosine is contraindicated in torsades de pointes, and it is used only with caution in WPW or Wolff-Parkinson-White syndrome. The reason for this is that if we slow AV conduction in WPW, the accessory pathway that is leading to the ventricles may take over as our primary conductor of impulses and generate ventricular arrhythmias. So we want to try to avoid that. And really, if you have the setting of WPW, an alternative to adenosine would be considering the use of amiodarone. Finally, using adenosine in a patient with asthma should be done only with caution because, as we've already mentioned, adenosine can cause shortness of breath. So be mindful of that. And that is it for us for our quick review of adenosine. I hope this was helpful. If you find our content helpful, we would really appreciate it if you would share with your colleagues or EMS students that may be getting just started in the field of EMS. That's really helpful for us. And if you are enjoying specifically these EMS medication videos, we do have a playlist on our YouTube channel that is entitled EMS Medications, where you can find similar videos for other EMS medicines. That's it for today. We appreciate you tuning in, and we will see you next time.